Good morning. My name is Beth Emery. I think most of you know that now. I'm past president of the Alamo Breast Cancer Foundation and ABCF's alternate to the National Breast Cancer Coalition Board. Welcome to the 28th Annual Alamo Advocate Program final session. Woo! We started this program at the request of the organizers of SABCS 29 years ago to enhance the educational and relationship building experience of patient advocates attending this scientific program. And so we're pleased to have all of you here and those of you who are online. We're proud to say that this year our Alamo Scholar class is one of the largest in our program history. 36 scholars, 30 of which are sponsored by Alamo, 4 by Teresa's Research Fund, and 2 by Metastatic Breast Cancer Alliance. They come from 16 states, plus Puerto Rico, and 8 countries. We also have 7 wonderful volunteer advocates serving as mentors. This year, the Alamo Advocate Program is dedicated to the woman who founded ABCF and the Alamo Advocate Program, Dale Eastman. We are delighted that SABCS also dedicated the first plenary session on advocacy yesterday to Dale. Now, one of the things that NBCC and ABCF do is we start all of our programs with a moment of silence, and scholar mentor Amy Russell Parliament will now come forward to do that.
Good morning. I have the honor of telling you about Ann Camden. Ann was diagnosed with breast cancer in 2009 and in 2016 with a second breast cancer diagnosis. Following her diagnosis, she funneled her energy into cancer advocacy, particularly in support of others navigating their cancer diagnoses and their treatments. She co-hosted retreats for Inheritance of Hope, Casting for Recovery of the Carolinas, engaging with women of all ages and all stages of breast cancer treatment and recovery to introduce them to fly fishing and peer support. Ann volunteered with many breast cancer groups, including as a helpline volunteer for Living Beyond Breast Cancer, and served on a patient advocacy board for Lobular Breast Cancer Association. She attended the NBCC Virtual Advocates Leadership Summit in 2022, and she graduated from Project Lead. Ann traveled across the country to advocate for metastatic breast cancer research and better health care for all. She connected with many by sharing her personal stories about living with cancer, including sharing her story through her blog, Down But Not Out, and through numerous other publications, including Wildfire Magazine, Brevity, and several other advocacy groups. Ann passed away on July 18th, 2024. Please join me in a moment of silence to remember Ann. Thank you.
Thank you, Amy. I'm going to introduce our moderator in a minute. Before I do that, the sponsors we want to thank, they're shown up on the screen. We have great sponsors, and we wouldn't be able to do this without them. Premier are Genentech, Pfizer, Menarini, Stemline, Lilly, Novartis, and Cybermedia Productions. Collaborating are Daiichi Sankyo, Merck, AstraZeneca, and Natera, and contributing is Exact Sciences. Now I'm going to turn the panel over to Dr. Nicholas McAndrew, who is a breast cancer oncologist at the David Geffen School of Medicine at the University of California, Los Angeles. He's the principal investigator on multiple past breast cancer clinical trials, including the NATALEE trial, for which he was the 3rd highest enrolling investigator worldwide. His research is focused on development of new therapies in breast cancer, as well as using biomarkers to help predict the response to therapy. Nick.
Thank you so much, Beth, for that introduction. And thank you to the Alamo Breast Cancer Foundation for having me help moderate this session. I really, one of my favorite parts about being a doctor is what my mom, who also is a breast cancer oncologist, taught me years ago, is that for her, the most rewarding part of being a doctor is patient education. And it's, I think, the reason why she's so beloved by many of her patients. And it's just my favorite part of my workday is just helping someone understand what's going on, what's happened to them, and how we can do something about it. And so it's for that reason that I really love to interact with advocates, because you sort of embody the highest level of passion for understanding this disease and trying to stop it. So thank you for all the work that you do. So today I just wanted to sort of set the stage with a simple sort of slide here, kind of putting into context some of the talks that we're going to hear from Dr. Rinker and Dr. Brufsky, and just kind of looking at mostly three, but also a fourth different, I guess, stage of the breast cancer journey. So starting with initial diagnosis. In black, I have the sort of most commonly known and understood parts of the process, and then in red I have what we're going to be focusing on as a sort of novel part of today's talk. So in terms of diagnosis for breast cancer, everyone's aware of screening and or diagnostic imaging if it presents as a palpable mass, and this is with mammogram and ultrasound or MRI. But Dr. Rinker is going to be talking about whether or not we can incorporate blood-based assays to sort of augment imaging and augment diagnosis and hopefully improve upon diagnosis. Next, once a breast cancer diagnosis has been made, we can talk about what the prognosis is, right? What's the risk of that cancer from either recurring or being cured? Typically, we think of things like stage, grade, and the biomarkers, by which I mean, of course, estrogen, progesterone, and HER2. But Dr. Brufsky is going to go through some of the genomic tests, which are tests on tumor tissue, to sort of better refine risk assessment and prognosis as well. And then in a very similar sense, going from prognosis to treatment selection, typically for selecting treatment we use, and this is just the same things in a different order that I have in the one before, looking at biomarkers, nodal status, grade, and tumor size as a sort of traditional methods to pick therapies. But Dr. Brufsky is also going to be going through some genomic tests, again, on tumor tissue to sort of aid in treatment selection in a variety of different treatment modalities. And then we won't be discussing as much monitoring, although I do think that it's an important topic to sort of consider because it comes up a lot from patients. There'll be, I think, a brief mention in Dr. Rinker's talk about this, but the current standard of monitoring is really just symptom-based monitoring. That's what the guidelines recommend. So if there are symptoms that suggest a metastasis, we do diagnostic imaging to sort of confirm or deny that. But down the road, whether or not these more advanced tests like circulating tumor DNA, are those going to be recommended as part of standard of care? And then also, would changing treatment based on minimal residual disease, is that something that is feasible or successful? This is not, again, not specifically going to be addressed in this talk, but it's somewhat related tangentially to some of the topics that we'll be discussing. And it's of broad interest, so I just wanted to sort of plant that flag there in case anyone was anticipating that. We can certainly ask questions about it. But so just with setting that stage there, I'll invite Dr. Rinker up, and she'll introduce herself as well. Thanks.
Hi, everyone. It's great to be here with you today. I'm Dr. Rinker. I'm a professor of biomedical engineering at the University of Calgary. I'm also an innovator and an entrepreneur, so I've spun out a company that's Scientra. We can start with, I guess, the first slide here. So I'm originally from the U.S., but I am in Canada right now, so happy to join you from up north. I trained at Duke University in biomedical engineering, and then moved to a location where there's a fantastic cancer center, very large cancer center, the second largest in North America, has just opened up there, a new facility. So very exciting place to innovate. So today I'm going to be talking about the breast diagnostics on the screening side is where I'm going to really focus. And I have a few questions. So I'm really trying to keep education at the forefront of this talk here. And so look forward to hearing your questions soon. But first is, where are we in breast screening? So a little bit of an overview of what's important in breast screening on the diagnostic side, screening gaps and opportunities. So how do we understand where we are, and then where we want to move into the future? Then what is important to look at for evaluating diagnostics? So all these new blood tests are coming out. What are we looking at? So when you're evaluating a protocol, or you're working on protocol review panels, or you're evaluating technology that's in the literature, what are some of the things that you might look for, taking a look at that? And then focusing a little bit on lab tests for screening. So there's emerging blood tests in this area, and just a little bit of an overview on those technologies. Then I'll also talk about how are we going to implement these technologies. It's a journey, right? There's an initial implementation, there's reimbursement, eventually you get to guideline incorporation. So it's this journey. So that's what I want to take you on today, is a little journey through where we are and maybe where we want to go. So just to set the stage here, at the first part, you hear a lot about risk assessment. So risk assessment can be based on genetic mutations, family history, even the complexity of breast tissue is a emerging area for identifying women that are at elevated risk of breast cancer. So you'll see blood tests coming out here, mainly focused on that identifying genetic risk for breast cancer, but also models that are taking into account these family histories and these other factors, including and some breast density. So I'm not going to talk anymore about risk assessment. So we'll go on to the next category, which is screening. So screening means monitoring for active presentation of the disease. And then secondary care means a screen positive. So when you're screen positive, going on to the secondary diagnostic imaging, and then on to biopsy and pathology for diagnosis. Okay, so just overall in breast screening, the target for breast screening is early stage diagnosis. Stage 1, stage 2 diagnosis. Many women, though, are not diagnosed at the earliest invasive stage, and this is for a variety of reasons, but we're not there yet as a society. We're not able to achieve that, getting everybody diagnosed at stage 1. So there's screening gaps for mammography, MRI, ultrasound, having access to the screening, having the ability to work it into the schedules. There's a lot going on with screening, right? There's also technical challenges with small tumor detection for mammography. And then with MRI, it's complex with contrast agent. So it's hard to work this into the schedule to be getting this every year or every other year as per guideline recommended screenings. And so these are some of the reasons why we're not seeing as much stage 1 detection. So the populations that are particularly difficult to detect at an early stage are women with increased tissue density, because the increased tissue density can mask the breast cancer. And then women that aren't screening at recommended intervals for whatever reason. So rural women located in rural areas, and it's not easy to get screened all the time, right? Okay, so just to go through a little, because I'm going to talk about tissue staging, so I thought I'd just provide a generic slide to explain where I'm talking about here. So I'm going to talk about tumor staging just from the size perspective. So T1 tumors being tumors that are 2 centimeters or less, T2, 2 to 5 centimeters, and T3, the centimeters greater than 5, the tumors that are greater than 5 centimeters. And now we're starting to get into the smaller divisions of the T1 stages. For example, T1C is 1 centimeter to 2, T1B 0.5 up to 1, and then T1A 0.1 to not more than 5. So T1As are advantageous potentially to find, and we're going to see that with the techniques such as MRI. And then there's micro that are smaller than that. Okay, so if we look at breast density as one of these issues, we see here breast density from A to D, and depending on the technique, oops, how do I go back? There we go. Okay. Depending on the technique, but it's generally 50% of women have C or D breast density. This is affected by a variety of factors, but we're looking at predominantly younger women, or skewed towards younger women. So 64% approximately of women ages 40 to 49 have C or D breast density. So as age decreases, mammography has a harder time of finding the small tumors, right? So as one of the reasons why we're not seeing a lot of uptake or decrease in the age of mammography use, because it's hard to find the tumors that are small sizes, stage 1 or stage 2, in the D-density breast tissue. So if we look at blood-based, what's going on here? Where there's a variety of pathways that can result in getting a signal. The top left there is passive secretion. So the cancer can actually passively secrete compounds into the bloodstream. You can have active secretion of materials such as circulating tumor DNA into the bloodstream. Going down to the bottom there, you see tumor shedding as number 3. This can be actual CTCs, circulating tumor cells that are shed from the tumor and go into the bloodstream. And then 4 is recruitment. So these are other cell types that are involved in picking up the signal from the cancer. So these are different ways and different analytes there in the middle that have been evaluated for either pre-diagnosis or post-diagnosis liquid biopsy type of tests. So circulating tumor DNA, circulating tumor cells, or circulating RNA, and different metabolites. Applications here correspond from screening through to prognosis and treatment response. Okay, so if we look at MSCED tests, they're picking up different types of molecules in the bloodstream. And then MSCEDs are multi-cancer early detection tests. So here is one in particular. However, the sensitivity of tests is, and I'll go into more about mammography on this, is stage-based. So you see lower cancer detection of the smaller tumors, lower percent of people that are actually have their cancers detected at the small size. And so as we move forward as a field, really looking to increase that early stage detection to increase the treatment benefits. Another one is circulating tumor cells that you may have heard of. Circulating tumor cells can be collected from the blood, and they're used a lot for looking at prognosis or treatment. You can sequence and use various techniques to look at the CTC composition, look at the genes in there to evaluate what's going on potentially with the cancer. So this is a busy slide, sorry about that, but this kind of summarizes from the Liquid Biopsy Consortium the different technologies in these kinds of blood tests. If you look at the bottom there, that's some of the analytes, some of the molecules and types of signals that you can detect. If you look to the bottom left, it sees technologies. Many of the technologies are based on sequencing or staining. There's also PCR-based platforms. So in our research, we've actually developed a new type of blood test, which we're calling a multi-target whole blood mRNA test. So instead of fractionating the plasma or fractionating out the circulating tumor cells, we take a whole lysed sample of blood and we pull out a panel of mRNAs from that. It's cancer specific for breast cancer screening with the panel, but this technology has multi-cancer capability. So just another slide on this. It's focused on the body's response to cancer, not looking at pieces of cancer. So this is a new way we're looking at to help target and really specifically detect those early stage cancers. Okay, so clinical implementation of tests. Currently the process is there's a screening mammogram for average risk women. You get a BI-RADS score. 1 and 2 is guideline-based follow-up. BI-RADS 3, 4, or 5 or zeros end up getting recalled into diagnostic imaging. So more specific diagnostic mammogram, ultrasound, MRI at this second step of diagnostic imaging. So if the diagnostic imaging is still concerning, then the positives will go to biopsy. And the biopsy is where there's a positive or negative biopsy result for diagnosis. A blood test, there we go, would supplement this process because there's guideline recommended screenings and no blood tests are involved in the guidelines currently. So a blood test negative would just be maintain screening. A positive would go into diagnostic imaging as the second step. Okay, so the current screening process is pretty inefficient, and this is highlighting here for young women, first-time screeners. And so out of a lot of people screened, a lot of people get additional imaging, and of that, a lot of people get additional biopsies, and very few are actually positive for breast cancer. So how can we, as we look to the future, help bring more efficiencies into the process and be more specific and catch those cancers earlier without having a lot of additional extra steps? So key points for evaluating diagnostics. This is imaging or blood tests. There's key performance indicators that you're going to want to look for: sensitivity, specificity, positive predictive value, and negative predictive value. And these numbers depend on a variety of factors that include where is the modality being used? Where's the technology, the diagnostic technology being used? Is it being used as a first step? Or is it being used as the second step? Because your populations going into those studies is different, so you're going to have different performance numbers. Cancer rate in the population. You have 1% prevalence of breast cancer in the average risk population. Say you have 3% average risk in a high-risk population. That's 3 times more cancer patients in that population. That's going to affect these performance numbers. Size of tumors in the population. So if it's a prevalent screen, you tend to have larger tumors, so you'll have better sensitivity in picking up those tumors. If you have what's like a regular screening population, they're screening every year, screening every other year, the tumors that you find are going to be smaller. And so that's going to potentially decrease the sensitivity of the diagnostic technique. So it's hard many times to compare the performance number between one set of studies and another set of studies because these critical factors tend to be different. Okay, so if we look at imaging-based breast cancer detection path, there is a pathway here from screening imaging. There's a recall rate. Sorry about that. There's a recall rate where a certain % of women will be called back into diagnostic imaging, and then a biopsy rate. If you look across each of these steps, there's a different positive predictive value for each step. So the PPV1 is on the screening imaging, PPV2 on the diagnostic, and then PPV3, which is also called the positive biopsy rate, is on kind of that biopsy positivity. This is the same slide with a lot more busyness. I just threw in some example numbers here. So for example, you would see screening imaging resulting in 10 to 25% callback. Sometimes you see lower callback numbers. It's jurisdiction dependent and technology dependent. Just another number here from a specific publication is 10% callback from the Comstock 2020 paper, a big multi-center study. Looking at this, and then we have diagnostic imaging with a 20% callback rate from the Comstock study, with resulting in a PPV3, so a positive predictive rate for mammography of 31% from the Comstock study. MRI, so the overall PPV for the process, for the screening process, is 5%. So you can see these PPV numbers can vary a lot. MRI has a higher PPV. So in general, we see in these studies, mammogram misses some of the cancers that MRI picks up, but MRI has an increased number of biopsies. So this is just kind of how performance analyses are typically performed in these studies. So I won't go into it much, other than the diagnostic has a number of true positives that it finds, and there's then a batch of actual positives. And that's the tricky thing in a lot of these diagnostic studies, is to have the gold standard of what is actually positive. Okay, so breaking down the Comstock paper data a little bit more, which is the mammography in comparison to MRI, we can actually get stage data. And by plotting the stage data, we say that mammography has a sensitivity of T1B less than 40%, and then it increases as your tumor size increases. So we need to look at this as a function of tumor size because that strongly affects the tumor sensitivity. And that's why you see in this suite of studies that is represented here in summary that the mammography sensitivity is low, but this is because these are very small tumors. Okay, so MRI finds very small tumors, and the sensitivity of mammography is dependent on tumor size. So these are lower numbers than you would see or you would expect to see based on the overall performance of mammography because of the tumor size effect. Okay, so I will move through this more quickly, but I've gone through here and looked at, for example, the performance calculations for screening mammogram from a second paper, the Low paper, that's summarized on the previous slide, where you can look at this flow. At the top, how many mammograms are given. On the left, mammograms that are negative. On the right, mammograms that are positive. And then below that, the number that are false negative or true positive, and then true negative or false positive. And then from those numbers, you then calculate your sensitivity, specificity, recall rates. So here we saw for this study 11% recall rate and a sensitivity of 31% with a 6.5% ppv1. And then going into MRI, we see much higher sensitivity, so 3 times more cancers, but at the expense of 2.5 times more biopsies. So overall, we see that the sensitivity of mammography screening imaging increases with tumor size and decreases with breast density, and that the recall rate for follow-up diagnostic imaging and the biopsy rate is really important for cost-effectiveness modeling. So what is that important for? Reimbursement, right? So we needed these technologies to be cost-effective for particular populations to get that reimbursement. So stage 1, sensitivity also drives a lot of mortality benefit, while the higher recall and biopsy rates increase the cost. Let me go forward. Okay, so also another thing in terms of evaluating diagnostic tests, there's many states. So as you see these innovation technologies coming out, they start kind of at the bottom center circle there on analytical validity. So is it measuring what it's supposed to be measuring really accurately? And then you move to the top part of the inner circle, which is clinical validity. Is it measuring what it's supposed to be measuring in a clinically relevant sample? And then on the outside ring, you see clinical utility. So this is how you use the new technology. What is the use case? What is the specific scenario? And is it does it have clinical utility? Is it resulting in change in practice? And then is it doing it in a cost-effective way for a particular target population? So with our multi-target whole blood mRNA, we have clinical studies that are international that have been ongoing since 2018, and then we have our clinical utility studies that are starting soon, our pilot studies for the clinical use of the test. So for this particular blood test and others potentially in the screening area, there's many possible paths that are involved, such as high-risk women alternating with MRI, women that have dense breast tissue using along with mammography or alternating with mammography to increase detection, and then secondary care after a mammogram to help the clinicians get additional information for the next steps for that individual. So in summary, there's gaps in technology, access, and uptake in the screening diagnostics, particularly for women with dense breasts that are at high risk or they're not screening. There's new multi-biomarker, high-complexity blood tests have the potential to complement imaging, complement our guideline-recommended screening. There's opportunities to bring forward these new screening tools, but it's important to engage the community to progress through this technology adoptions from, understanding where it is at the beginning and how do we all work together to help these technologies generate the data to support additional reimbursement and expansion into the market and eventually into the guidelines. So, thank you very much. I should should have announced you.
Okay, not a problem. It's not a problem at all. All right. So let me kind of change gears here a little bit. There we go. So, I'll introduce myself first. I'm a professor of medicine at the University of Pittsburgh, and actually I'm in my 30th year this year at the University of Pittsburgh. It's been a long time. Thank you. I came, a long time ago. I'm a molecular biologist as well as a breast cancer medical oncologist, and I decided many years ago that I wasn't going to have a lab, but actually instead apply the principles of molecular biology and some of the techniques that we have to help women and the occasional man with breast cancer really make clinical decisions. I think that our science and our medicine is only as good as it helps you, the patients and the advocates, make decisions that you need to make. I also have been very involved, like Nick, with many of the clinical trials I think you're very familiar with over the last 30 years. So it's kind of been a parallel track to my own career. I used to run the breast program there for about 25 years. I stepped down a couple of years ago to let the younger people kind of take over. But anyway, so these are just my competing interests. And I think most of you in this room either have breast cancer or were involved with somebody who had breast cancer, many of you who had early stage breast cancer. And the most common breast cancer people have is estrogen receptor positive. Early stage breast cancer is probably about 60%, 70% all breast cancer. And these are the questions I think you have. And I think many of you had these questions when you talk to your oncologist and your surgeon. I think the biggest one, and the one that we spent a lot of time in our business over the last 30 years trying to figure out, is can I avoid chemotherapy if I have estrogen receptor positive breast cancer? Related to that is, okay, I need it. What's the benefit? If it's only 1 or 2%, do I really want to do it? I don't think so. And so giving people absolute numbers has been really important. We used to do this, I've been in this business long enough, based on clinical trials. We would tell you, okay, your benefit from chemo is about 1/3. But can we be more precise with that? And I think we have molecular biology, molecular tools that have helped us do that. There are some related questions that I think we have kind of talked about. They're not as popularized, though. One of them is, do I need endocrine therapy at all? I think we saw at this meeting, Ladera, which is giredestrant, and if some of you have been on that trial, it really has a lot less side effects than an anastrozole, than Arimidex, and some of the other ones that we use. And I don't think people realize that. And when they were going, the side effects aren't that bad, they're bad. I mean, as someone who's been taking care of women with breast cancer for 20 years, the side effects of Arimidex are pretty bad. And I think that we will find with the oral SERDs that the side effects are going to be much better. I think that's going to be one of the big things we're going to find out with this drug, although it's very, very expensive, and I think it's going to be a real issue, but that's a whole other talk. But we have tools now. Potentially they can tell you whether you need endocrine therapy at all. And I've used them now in clinical practice. They're not as widespread, I think, as they should be in the breast cancer community, but we have tools that can do that. Related to that is that probably about 7 to 10 years ago, maybe a little longer, at this meeting, we had a trial called NSABP42, where women were given 5 or 10 years of endocrine therapy, and about 3% of them had a benefit from it. And I think that, the issue is that, do you need extended adjuvant therapy? I mean, you're already on therapy for 5 years. You really need another 5? Is it really going to help? So we have tools for that. And then there's some other tools that are kind of related, that some of them are new and some of them are really literally around the corner. One, you come in and obviously you're going to need chemotherapy. You have a large breast cancer. The question people ask is it really going to work? The worst thing for us as medical oncologists is to give people chemotherapy for 6 to 9 months to try to shrink their cancer, and it doesn't shrink at all. It's the same. And we kind of look at ourselves and go, wow, this is crazy. Why did we do this? And so we have molecular tools potentially to tell us who is going to have a complete response to chemotherapy. Finally, and I'll just briefly mention a few things that I think are literally right around the corner. One, we've been using anthracyclines like adriamycin for almost 30 to 40 years in breast cancer. We spent the last 10 years trying to figure out who really needs it, because these drugs can damage your heart and do some other things. And we now potentially have tools to tell us who needs it and who doesn't. Another one is that we're now potentially using immunotherapy, not only in triple-negative breast cancer, it works really well and has changed the paradigm in women with triple-negative breast cancer. But we also now have tools, potentially, to know whether we need immunotherapy for estrogen receptor positive breast cancer. And finally, I think we have a lot of data on CDK6/4 inhibitors. They really also, I think, have somewhat changed the natural history of breast cancer in early stage, and definitely in metastatic therapy, but maybe even in adjuvant therapy. We now have large clinical trials, and some of you in the room may have been offered, adjuvant ribociclib or adjuvant abemaciclib. And I think we're really actively searching for tools that can tell us, a molecular test that can tell us whether you need CDK4/6 inhibitors or not. And really the goal that people like me have had is to be able to do this all in one test off a core biopsy, and tell you the results within about a week or two. That's really what a lot of us are moving toward, and I'm going to tell you a little bit about that during this. So obviously you can't see this, but there are multiple trials that have been done with multiple assays. I think many of you are familiar with these or have heard of them or even participated in some of these trials. TAILOR-RX for something called Oncotype DX, the 21 gene assay. RxPonder is the 21 gene assay for node positive disease. MindAct is something called the 70 gene assay or MammaPrint. And ADAPT, which is kind of basically using the Oncotype assay, but doing a biopsy of your tumor after 2 to 3 weeks on endocrine therapy to see if the proliferation rate goes down. And if it does, then potentially you can avoid chemotherapy. So we have a lot of tests like that, but I'm really going to focus on a few. I'm going to focus on the 21 gene assay. This test was developed probably in the late 1990s, early 2000s. And at the time, we were learning about how to measure RNA in blood for HIV, because that was a big thing back then. It still is a big thing now, to know whether the drugs were efficacious, whether they had benefit in HIV. And a bunch of people got together and said, why don't we do this in breast cancer? So they picked 400 genes, and they had a trial called NSABP-B16, which was tamoxifen versus no therapy at all. And they had 10 years of follow-up on that. And what they did in that trial is that they said, okay, we're going to pick the 16 genes that work the best. There's 5 genes there that basically do what's called normalize the RNA. So they can do a block from anywhere. Some blocks have a lot of RNA, some blocks have a little RNA, but the tissue block from your tumor. And they took those 16 genes, and you can see them here, and they made an equation that resulted in what's called a recurrence score that I think many of you are familiar with, that predicted whether you had a high risk of recurrence, an intermediate risk of recurrence, or low risk of recurrence. And that was enough, but they went further, and a lot of us were very involved in this trial called TAILOR-RX, and they said, okay, what's your recurrence score? And we're going to see if your recurrence score is under 10 in this TAILOR-RX trial, we're not going to give you chemo, we're just going to give you endocrine therapy at all. If it's over 25, we're going to give you endocrine therapy and chemo. But if you're between 11 and 25, we're going to say, okay, let's randomize you to endocrine therapy with or without chemo. And we now have data, actually we have 15-year data, but Joe Sperano, who is the principal investigator of this trial, presented here about 3 years ago the 12-year data. And what you can see here is that if you have an oncotype of 10 or less, what you see here is your recurrence score, your recurrence-free survival is over 90%. So the chance of getting a distant metastasis is under 10%. If it's over 26, without CDK4/6 inhibitors, it's about probably 15%. If it's between 11 and 25, what you can see here is that basically it's about a little under 10% chance of getting a distant recurrence, and chemo doesn't make a difference. And so this told about half of the women that we had that didn't need chemotherapy. They did the same thing. That was node-negative breast cancer. It's node-positive breast cancer. Many of you are familiar with the RxPonder trial, very similar design. If you had a recurrence score of 25 or greater, you got chemo and endocrine therapy. If it was under 25, you got endocrine therapy with or without chemo. And in this trial, in the postmenopausal women, if you had a recurrence score under 25, you didn't need chemo, which was great. Coming with 3 nodes positive. In the past, we would have given everybody chemotherapy. We didn't have to. If you're premenopausal, though, and you can see here, there was a benefit. And it was about probably a 5% benefit if your recurrence score was between 14 and 25. And all of us were really mystified by this. What do we do? Does chemo really work in premenopausal women? And it turns out probably what it does is cause menopause. It causes ovarian suppression. There's a test called anti-Müllerian hormone, which tells you whether you're in menopause. You may be having menstrual periods, may be spotting, may not have them at all for a few years. And it turns out, we don't know. Whether you're in menopause. We can look at your estrogen, sometimes it's high, sometimes it's low. But anti-Müllerian hormone is what is used by the reproductive endocrinologist when women come in for infertility counseling. And Kevin Kalinske, who was the PI of this particular trial, actually looked at AMH and found that if your AMH was postmenopausal, you had no benefit from chemotherapy in our responder. And so what that means is that probably it is due to ovarian suppression. Now, we have a randomized trial to try to figure that out. It's called Offset. Again, you may have heard about it, you may have advocated for it, heard people on it, where women who have oncotype scores that are low risk, we're randomizing them to either receive ovarian function suppression aromatase inhibitor with or without chemo. Some of us feel that trial is unnecessary, but on the other hand, it is accruing, not fast, but we're doing it anyway. So our group actually looked probably about 15 years ago at the oncotype and realized most of the score was coming from things we could measure by immunohistochemistry, because the oncotype is about $3,500. And we said, okay, can we come up with something cheaper just looking at the slide itself and judging the oncotype score? And we did something called the McGee equations. They're available right now online. You simply put in the Nottingham score, the ER, the PR, whether it's HER2 positive or negative or not, the tumor size, and the Ki-67, all of which are available on a pathology report, and it will give you the oncotype score. And it works pretty well. This is data that we had from probably about, I think this trial is almost over 15 years old, 14 years old. And what we found is that if you had an estimated McGee score that was high, it was never low. And if you have an estimated McGee score that was high, that was low, it was never high. So in other words, we never had a score that we estimated by the McGee equations that was under 25, that was ever over 25 by oncotype. So it's a really good way of doing this, and I do give this talk around the world, and actually there are places in the world that just can't pay for oncotype, and you can do this. And so we've done this in our practice quite a bit to kind of figure out who really needs to get genomically tested. And it turns out, if your McGee score is under 18, generally we tend not to test you. If it's over 18, we tend to test you. But really what this told us is that there have to be better ways of looking. And actually, MammaPrint, or the 70 gene assay, is a slightly different way of looking. It involves almost no genes that we typically measure by immunohistochemistry. These are 70 genes. And the way this was developed, on about 70 women with node-negative breast cancer, all under age 55, who either relapsed and didn't. And they chose the 70 genes that were most associated with relapse. There was a large trial, just like TAILOR-RX, called MIND-ACT. Again, many of you, I think, are familiar with this trial. But again, in MIND-ACT, you had a clinical risk. We looked at you and decided, based on what was called adjuvant online, which was actually developed here in San Antonio recently. It was Peter Ravden developed it, who was an oncologist here. And when we retired, it kind of went out of use. We have another test called Predict Plus for that. But nonetheless, you had a clinical risk by adjuvant online, you had a genomic risk by MammaPrint, and if they both were low, you didn't get chemo. If they both were high, you got chemo and endocrine therapy. If they were discordant, that is, if you had it high and we were going to give you chemo, but the MammaPrint came out low, you were randomized to chemo or no chemo. And in fact, let's go through this trial. These were fairly ill patients. 10% of them were HER2 positive. And in fact, of the HER2 positive patients here, 20% were actually MammaPrint low risk. So you imagine coming in, having a lymph node negative breast cancer, and your oncologist, saying either get TCHP, this mega chemo, or just get endocrine therapy. It's quite a difference between the two. And we've had a big debate about whether women who are low risk by MammaPrint and HER2 positive should be getting chemotherapy. But that's a whole other issue. But again, in this trial, if you were under age 50 or you're over age 50 and had a low risk MammaPrint, at 8 years, your distant disease-free survival was 90%. So you only had a 10% risk, very similar to our responder and TAILOR-RX. But if you're under 50, the same thing happened, that you had about a 5% benefit to chemo, and it's most likely you had that chemo benefit because you had ovarian suppression. And we have trials that are 30 or 40 years old where we've tested this. They've been lost to history. I think that maybe we'll kind of start talking about them in meetings again, where we did this. We tried a drug with a regimen called CMF versus ovarian suppression and endocrine therapy 30 years ago, and there was no difference. And I think we're going to revive a lot of this in the near future. But again, that's kind of what we're seeing here in some of these data. But more importantly, what MammaPrint did is that it not only gave us high risk where you needed chemo and low risk where you didn't, but it turns out it can be divided a little bit more based on the actual score. There's something called ultra low, there's high 1, and there's high 2. So it gives you a little bit more precision in our testing. And so the first thing that we did was look at these ultra low patients and ask the question, Do they need chemotherapy at all? And this is a trial that was done actually several years ago. It was published probably 4 or 5, actually 7 or 8 years ago, where they looked at a trial called the Stockholm trial. And this is a trial from the 1970s, 1980s, where people didn't even know whether they needed chemotherapy or endocrine therapy or not. So this is a trial where women basically were randomized to mostly postmenopausal. They were randomized to either receive tamoxifen for 2 to 5 years or nothing. And so this being Scandinavia, they did very good record keeping. They had all the blocks that were available. They had 20 years of follow-up. And we looked at the patients who were mammoprint low risk in this trial, about 15%. So these are people with ultra low risk mammoprints, and asked the question, what was their benefit? And these women with no therapy whatsoever and an ultra low risk mammoprint had a 20-year breast cancer specific survival of 94%. So potentially these are people who need nothing, who come in. And these are, you would be surprised, these are not people with really, really low risk cancer, really high estrogen receptor positive breast cancer. You'd be surprised at who the women were in this trial, and that the molecular test actually told us potentially who could come in and not get chemo. So you not get endocrine therapy. You're basically getting, you're miserable on your Arimidex, and you get a mammoprint, and maybe it's like ultra low risk. Maybe you can stop therapy whatsoever. This is only one trial. This is a second trial, actually, that shows this. The same thing happened in this MINDAC trial that I showed you before. It's 1,000 women. And in this trial of 1,000 women, you had an ultra low risk mammoprint. It didn't matter whether they had therapy at all. You had a 95% chance 8 years later of not having a distant recurrence, just with an ultra low mammoprint. And so, again, this is now in the NCCN guidelines. It took a while, but it is in the guidelines. And some oncologists do it, some oncologists don't. I think we're all still doing Oncotype a lot. But again, this is a test potentially that could tell you whether you needed therapy at all. So that's one thing. The other thing is who needs 10 years of endocrine therapy. I talked about this trial, NSCB 42. We actually talked about it at this meeting again. They had some other tests that were done. But in this trial, the absolute benefit is 3.3%. And the question that we asked is, can we have molecular tests that can tell us whether it works or not? And there's a bunch of tests. I'm only going to talk about one, just to kind of give you an idea, and that's this mammoprint test. That the 70-gene test, if you're low risk, basically you got 10 years of endocrine therapy, you had an absolute benefit of 10% in terms of recurrence risk. So this told us who needed it. What was really interesting in this is that there was another trial called IDEAL. It was done in Europe. Very similar design. It was basically women getting 7.5 years of endocrine therapy versus 10 years of endocrine therapy. And we did the same thing. And the weird thing about this, if you were high risk, that is, it was kind of opposite. It was counterintuitive to what you thought. So in other words, if you were high risk, you had no benefit to the extra 5 years of endocrine therapy. So in other words, you had all of your benefit was taken care of by chemotherapy in the first 5 years of therapy, which is weird. So it's kind of opposite of what you thought. Oh, you're high risk, you need to be on endocrine therapy for 10 years. No, it's the opposite. You're high risk, maybe you can get away with 5 years. But in this case, if you were low risk, actually, you had a 10% benefit, absolute benefit. So these are the women potentially who needed 10 years versus 5 years of endocrine therapy. So we have a test now for this as well. And I'll briefly, because I want to give you guys time to talk, I'm not going to talk a ton about other things. I'll try to keep it brief. I could talk forever about this, as you can tell, but I think it's really you guys need to ask questions as well. But there are other issues with this as well. If you look at the other side, high 1 and high 2. So high risk, yeah, you need chemotherapy or at high risk of recurrence. But again, there are subtleties to this. High risk, high 1 and high 2 biologically are two different kinds of diseases. And one thing, for example, is that you can actually take some of these mammoprint highs, and there's another thing we can do. We can actually look at what's called intrinsic subtype. Luminal A is estrogen receptor positive, that's slow growing. Luminal B is estrogen receptor positive, that's fast growing. HER2 is responsive to things like trastuzumab, Herceptin. And then finally, basal is like triple negative. It looks for all intents and purposes like an estrogen receptor positive breast cancer, but he behaves like a triple negative breast cancer. And this is an analysis of 1,000 women that was done by a bunch of surgeons about 10 years ago in a trial called NBreast. And it turns out you can take 1,000 women, of which about 500 look like they're estrogen receptor positive breast cancer, and 20% of them are triple negative. And you treat them with endocrine therapy, you don't give them chemo. Maybe they need chemotherapy instead. Maybe they need like this Keynote 522 regimen that we use with immunotherapy. And so this is kind of what it does. But we can actually divide it even further. This was actually presented last year at San Antonio, We looked at this high 1 versus high 2 and looked at the incidence of people getting chemotherapy and what was their pathological complete response rate. Who had no disease left over at the end. And it turns out low risk, luminal A, very slow growing tumor, only 4%. And we all know this. This is something that's known to breast oncologists. A lot of you who've done advocacy probably know it as well. But the interesting thing is when you look at the high risk patients, if you were a luminal 1, you really only had a 10% PCR rate. However, if you were a high risk luminal 2, it went up to 30%. And it didn't matter whether you had lymph nodes involved or not. If you were high 2, you had a much higher chance of pathological complete response. So we took that even a little bit further. Because one of the questions we have is, who needs anthracyclines or not? Who can get away with maybe, a taxane and Cytoxan instead of getting a taxane, anthracycline, and Cytoxan? And I think those of you in the room who've had, adriamycin or epirubicin or something like that know that it's a fairly toxic drug. You have to give it through a port, you have to get echocardiograms, it can cause heart problems. And so if we can get rid of anthracyclines, it's a good thing. And so again, we looked at this very carefully. We have a very large registry of about 25,000 patients, going up to 30 to 35,000 patients called FLEX. If you get a mammoprint, you're actually asked to be enrolled in FLEX. We look at the entire genome, all 22,000 genes, instead of just the 70 as part of the test. And we follow you for we have median follow-up now of about 5 years in this trial. And we looked at the women in this study who got neoadjuvant therapy either with an anthracycline or without. And if you were a high 1, you had a PCR rate of about 7%, regardless of whether you had ACT or TC as neoadjuvant therapy. However, if you're mammoprint high 2, you can see there's a substantial difference. Now, these were small numbers of patients, so we looked a little bit further into FLEX and looked at 3-year survival in people getting adjuvant or neoadjuvant therapy. And it turns out if you're mammoprint high 2, you had a 10% benefit to anthracyclines. Mammoprint high 1, it was the same. You did really well. It was like 95% 3-year survival. But again, we are now applying this to larger data sets, to randomized clinical trials. There's a trial called ABC, which is a randomized trial of TC versus TAC. We're applying this test to it right now to see if this really is confirmed in a larger data set. And again, this is also done with Oncotype. So Oncotype did the same thing, although they're not pursuing this any further. If you had a recurrence score greater than 31, it looks like you had benefit to TAC as adjuvant therapy as opposed to TC. Let's go through this part. 2 more quick things, and then again, I really want you guys to talk. We shouldn't be hogging the whole spotlight here. We have data now in ER-positive breast cancer that if you give immunotherapy as neoadjuvant therapy, like triple-negative breast cancer, that you actually have a benefit. This is a Keynote 756 study. It was presented here, actually, about 2 years ago. And in the Keynote 756 study, you can see here, if you have an estrogen receptor, if your estrogen receptor on your tumor is less than 10%, what you see here is you've got a 50% PCR rate. So 50% of the patients have no cancer left after getting chemo and pembrolizumab. But that's only a very small number of the patients in the trial. Only less than 5 or 10% of the patients were like that. If your ER was over 10%, you can't get pembrolizumab. Number one, it's not approved. And number two, if half of the patients had an ER greater than 10% and a PD-1, which is another test of immunosensitivity, of less than 1%, you have a PCR rate of 7.5%. So can we find molecular tests that help us do that? And yes, we can. There's a trial called I-SPY that some of you may be familiar with, where we're testing various kind of new therapies in the neoadjuvant setting. And it turns out that if you're mammoprint, everybody has a mammoprint in I-SPY. If you're mammoprint high 1, your PCR rate to immunotherapy is about 18%. If you're mammoprint high 2, it's about 65%. So we now have a randomized trial that's open. It's accrued about probably 250, 260 patients. It's called SWOG 2206. That if you come in with a large ER-positive breast cancer, you are allowed to get a free mammoprint. It's free. Normally it's about about $3,500, but it's free. You get a mammoprint, and if you're mammoprint high 2, you're randomized to typical chemotherapy, which is usually ACT, with or without durvalumab, which is an immunotherapy. And this is a really cool trial, and hopefully the mammoprint high 2 will predict for people who have a better benefit from immunotherapy and tell us, look, these are the people who should be getting immunotherapy with ER-positive breast cancer. So the final thing, and I think a big thing, it's been kind of in the background of this meeting, it's been the background of ASCO, the background of ESMO. We have these CDK4/6 inhibitors in the adjuvant setting. They're very expensive. I think many of you have heard the statistic For each recurrence, it's about $14 million of expense. And so we really want to know who needs these drugs. And I think we're starting to think about this. And we've looked at this a little bit with the mammoprint assay. And it turns out that we have kind of various signatures for, CDK4/6 inhibitors affect a protein called RB. And so we have these signatures that predict for RB loss and RB lack of function. And it turns out, at least when we look at our mammoprint 70 gene assay, they seem to cluster in the mammoprint high 2. And the mammoprint high 1 seem to be sensitive. The lows, the ultra lows, seem to not be sensitive, but mammoprint high 2 seem to be resistant. And so we're kind of approaching, various companies, to try to say, okay, let's try to use this as a biomarker. And I think, this is one of many. There's something called RB-Sig that was shown at this meeting. It didn't work. It was tried on one of the big trials. It didn't work, but we're trying things like this to try to figure this out. This is a very, very important question, not only for the cost, but for the patient, for you in front of us. Who really wants to be on ribociclib for 3 years or abemaciclib for 2 years when you've been through so many things already? You've had 6 months, a year of therapy already. And I think for us to know, if someone came to you and said, listen, you're going to get no benefit, you wouldn't do it. If someone came to you and said, wow, you're going to get a 10% or 15% benefit, I think a lot of people would do it. And that's what we're trying to do. This is really the cutting edge of our business. I didn't even talk about circulating tumor cells or anything like that because I would have been here all day doing that. So, we really, I think, still have a lot of really interesting clinical problems that affect you directly that I think molecular testing is helping us figure out. And so again, this just shows you this at the end. This is just the last thing. I think this is really interesting. This is done more in Europe than in the US. Can we replace chemotherapy by a CDK4/6 inhibitor? And so we now have these trials where people are in Europe. This is not being done in the US yet. There's a trial called ADAPT cycle, where basically if you have a diagnostic biopsy, they'll put you on endocrine therapy for 2 or 3 weeks and then rebiopsy your cancer. And if the Ki-67, which is a measure of cell proliferation, goes down, then you're randomized to receive chemotherapy or, in this case, ribociclib and an aromatase inhibitor. So this is, we're trying to replace chemotherapy entirely using a biomarker, which I think a lot of us believe should happen. We just don't know 100% who it is, but I suspect within the next 5 years or so, we're going to have data that suggests women who ordinarily would have gotten chemo and then got ribociclib or abemaciclib will likely simply just get the aromatase inhibitor and a CDK4/6 inhibitor. That's where we're going. But again, this is the vision. This is my vision. I think this is all of our vision. Really is to have a core biopsy when you're first diagnosed. And again, within a matter of days to a week or two, tell you all of this. Let you know and be able to tailor your therapy specifically. Do you need chemo? Do you need endocrine therapy? For how long? Do you need anthracyclines? Do you need immunotherapy? Do you need CDK4/6 inhibitors or not? And I think that we'll be able, within the next probably 5 to 10 years, if not hopefully sooner, have genomic tests that do this for you. And that's not even talking about all the circulating tumor DNA, which is a whole other thing. And it's not talking about all these artificial intelligence evaluation of the past slides. We're going to add that too. And so hopefully we'll be able to refine what you need and really eliminate a lot of the toxicity of the treatment for the vast majority of people we treat. So again, I went a little bit longer, and thank you very much.
Thank you so much. So while we wait for folks to come up to the microphone, I just want to get started with a couple questions and thoughts, and I wanted to start with Dr. Rinker. So, one of the things that I've noticed a lot in just my clinical practice and also just in what's commercially available in the marketplace is a lot of these tests, these novel, especially multi-cancer detection assays, you have that beautiful circle of analytical validation, clinical validation, and then clinical utility. And I have to compliment you and your company's website for, I took a look at it earlier, and, there's a lot of excitement about it, but where you, I think, appropriately stop short, where other companies don't stop short, is they make it sound as though the clinical validity part is the utility part. And they make these assays commercially available before they've been demonstrated to be useful, which I think is, I'm concerned about that because I do think that breast cancer patients or patients who are at high risk of breast cancer are a vulnerable population, and they may be sort of swayed towards using these assays are having to pay for them out of pocket before they've actually been demonstrated utility. Can you comment on that at all, and sort of whether or not you're seeing that at all?
Yes, so it's interesting because in blood tests you can get LDT approval, so that's a laboratory developed test approval in North America. So this is in the US and Canada. So in the US it's through CLIA. So CLIA certification enables the availability of the test from a regulatory standpoint. And you can work towards reimbursement, and reimbursement requires the clinical utility piece. So again, it's a little bit of a different pathway from the drug side of things when you need the FDA approval, and so there's a lot more publications and data, multi-center studies, for example. Whereas in the lab test area, you're gonna see some of these things come up, which is why I thought education was a really important piece to be sharing about this today. However, we do need ways to be able to work together with the clinical community to use the tests to generate the additional data in a safe environment. So one of the things that we're doing is there's medical oncologists that are actually screening women, and the medical oncologists understand both pieces. So I think, we'll see a lot of implementation initially in the high-risk population, because these are women that are actively going and getting screened, and enabling both technologies, right? Guideline recommended screening, as well as the new technologies to generate that use data. So yes, you just, as with everything, you just have to be aware that there are LDT approved tests that are out there, and just ask, what are they being used for in particular? Because there's quite a gap. There's a lot of gaps in the process between risk assessment through treatment decisions and recurrence, and finding the right use for the right test at the right time for the right person.
We'll start with a question from this microphone.
Hi, thank you for great presentations. My name is Maureen Terranova, and I'm from Rhinebeck, New York. My question is for Dr. Rinker, specifically about, you presented a lot about the guideline-based screenings that exist currently, and I don't know if you saw the presentation in the general session this morning on the data from Wisdom and the risk-based screening that was proposed there. And so I guess I just want to hear your opinions about what was presented. I understand that risk-based screening would require genomic screening in the population, which I understand is, a logistical barrier at the moment. But what is your opinion, and what is your sort of advice to us as advocates to take that information and hopefully get us, because it seems like moving away from guideline-based screening is really what we need to do, and to go more towards a risk-based strategy. Is genomic screening of the population really the best way to go, or is there another way to get at risk-based screening?
Thank you. So no, I unfortunately missed that presentation this morning, so I can't comment on that one in particular. What I see in the area, though, is a lot of different, still a lot of development in the area. So different risk-based tests are good for different populations, and we're still not seeing, of all the cancers that are diagnosed, not a large percent of them actually would fall under high risk. So that's my worry. My worry is that we are not quite there yet in terms of demonstration of being able to capture most women by a risk stratification approach. And so as we continue to push that, it's a very important thing to do, get risk stratification early, at an early age, to get qualified for the accelerated screening at an early age, for those that qualify for high risk. And I think we need to continue to push for better and maybe combination of tools in the risk stratification area, so that we can get a better understanding and properly characterize and have clinical studies that support that risk stratification actually leads to early detection and mortality benefits, because right now I'm not seeing that we're actually want to get rid of general screening just yet. I think we have a lot that we can do kind of in parallel as we move towards the future of precision medicine.
Yeah, and so it's for those who didn't see the Dr. Esterman's presentation on the Wisdom study. It is really amazing, and I think it was extraordinarily well received. And I think I wouldn't be surprised to see that picked up faster, than we'd expect for routine clinical practice. But sort of for summary, it had showed that this multimodal risk assessment, which include, beyond sort of like a 9-gene mutational panel, sort of germline high-risk genes, but a comprehensive risk assessment panel. And they were assigned into sort of, I think it was 3 or 4 different risk groups. And they were randomized to this higher risk screening paradigm versus an average risk. So there was still general risk screening algorithm that was taken for other patients, and they showed that it was an extraordinarily positive study, and it was more cost effective. It did not result in more sort of like larger tumors being diagnosed by kind of focusing the screening more on the high-risk patients and allowing the sort of lower-risk patients to have a less intense screening protocol. But I think that as it just demonstrates to me that a comprehensive approach rather than just a single test for all types of women is going to be really better, and potentially incorporating blood tests if they're able to sort of augment, especially a high-risk population. That I think that's the future.
Well, I mean, the thing is that we do this in cardiology now in medicine. We do risk-based screening in cardiology. And it's like we forget that as oncologists. It's already being done. It's accepted by everybody. And I think that it's definitely where we're going. I think as advocates, I think the big problem is going to be the cost and kind of the stigma or lack of stigma around genomic testing and getting people to do it. I think that's going to be probably the big thing as advocates that everybody can do. Yeah. But we do it in cardiology, and there's no reason why we shouldn't be doing it for breast cancer.
I was really happy to see, though, that it was the most cost-effective model of all
right.
of all of the sort of general guidelines, too, which is sort of was, I think, surprising, but really nice to see. Yeah. Yes.
Hi, I'm Judy Perkins. I'm with the Alamo Advocate Committee here. I also represent the National Breast Cancer Coalition and the Florida Breast Cancer Foundation. My question is much more big picture. This whole week, I have sort of been reliving my cancer journey and just the horrible decisions I made before I was an educated advocate. And, everything from an axillary dissection for DCIS to starting IV chemo when I was stage 4 to an oncologist trying to get me to take CDK4/6 inhibitors, even though I had RB1 loss. Like, the gap between the people who are in this building and the people delivering treatment who are not in Houston or San Antonio but are out further afield, like, how do you get them to not wait 10 or 20 years to start delivering current standard of care? I don't know what it takes to get things into the NCCN. I don't know how to get these people up to speed faster, and maybe this is the wrong panel to ask that question. Just last night, I was in a presentation Laura Esserman gave, and they were talking about women in Texas, dying in the parking lot because their water had broke and they weren't going to give them an abortion until they were practically dead. And philanthropically, they went around and trained all the ER doctors in Texas, so at least that is not happening anymore because everybody was so afraid of being persecuted. So there was an effort, there was like a philanthropic outreach effort to educate the people on the front lines. And I don't know, do we need something like that in the oncology space? I'm sorry to just ask. I don't know. Do you have any?
It's a good question. I think it's an important and great question, and I think it's, speaking as a breast medical oncologist, I feel spoiled that it's the only disease I have to focus on. How nuanced breast oncology has gotten, I think, speaks to your point. It has created this especially difficult problem of educating the general oncologist, who is, there's so many different factors there, and I can't say that I have have an answer to it, but I think there are, genuine, I think real challenges, even amongst sincere general oncologists who want to try and do best. I mean, it's become a very, very complex field. None of it's to excuse any sort of, or even, lack of attention, sort of, and desire to continue to educate. But no, it's a hard problem.
Yeah, I think the guidelines are not perfect, but I think it's a start. I think before NCCN, it was real Wild West. At least it's now narrowed it down to 50% Wild West. I mean, that's the thing. So you just keep pushing it, keep promulgating it. I think, the boards, our medical boards, now we have continuous education for our boards. And so we have to kind of get recertified every 3 months by doing 30 questions. A lot of them you refer directly to the breast cancer guidelines, and so to NCCN in particular. And I think that sort of thing is going to be the only way to do it. It's hard. It's an information thing. As Nick kind of said before, it's really tough when you deal with 15 different cancers to stay up to date on all of them. But I think that it's getting there. It's not perfect, but it's getting there.
Yep, there we go.
Perfect.
Carolyn Royce. I am a first-year scholar here with the Alamo Breast Cancer Foundation, my first time to SABX, and wow, it's been a great week learning so much, and thank you so much for your presentation and everything that you do, because it's going to make a difference for us, the precision medicine, or, understanding how to treat people better. So all the crazy side effects we've heard about this week from just our offline conversations about joint pain or falling and neuropathy and things like that, you're going to help people. So just a quick +1 on what she said. We definitely need to make sure that we're moving as fast as we can, right? Because some of us here, like me, are MBC, and, time, you never know. Well, nobody knows. But in any case, to your question about the cost and should we, go slow with some of these tests are low risk for us. You give some blood and then you find out more information. I mean, let's figure out the costs and how to price it right, but let's also educate the education isn't happening fast enough. The circulating tumor DNA, like you said, is a whole nother conversation, and that should be standard of care for lobular, which is my question. I saw nothing about lobular in any of the risk scoring. And so, especially at Pittsburgh, there's, a great Steffi team and whatnot who's helped us identify that's 15% of breast cancer. So that's not insignificant. It's more than ovarian, right? So let's, how do you, in your scorings, the one that's online, the one that's in your blood test, or for the screening, how do you factor lobular? Because I've seen a few presentations on oncotype and lobular, and when you get a low oncotype score, typically in lobular, it's not always going to assess your risk right.
Yeah, I mean, I think it's being done, believe it or not. I think, again, it's just the lack of, the way things work is you have to have an interest in it and enough of a as you know, in Pittsburgh, there's now a lot, and MD Anderson, a bunch of other places around the world, there's now a real interest in it and really kind of subdividing out lobular. As you know, we did that with oncotype. We said, okay, oncotype lobular, it looks a little low, but we didn't investigate it enough. And it turns out it's probably not as sensitive, I think, as it is in ductal. There is movement toward there. I think, people were wanting to just get the most out of everything and just do the majority. But as we get more and more individualized, I think there's a real need for doing that. And I think it's being done. We're getting there.
And I think there's also a lot of desire to, on part of the, both the research community and just the general med-onc community, that they really want to know how the lobular subsets of patients do in these big studies. So in the Natalie trial, in sort of pitching some of the sub-analyses that are done, I was speaking with Novartis, and I was like, have we thought about looking into, they're like, don't say lobular. Everyone tells us lobular. they're like, don't worry, we're doing it. But I was so happy to see that was like, first and foremost, one of the main areas that people really wanted to know, now that we've refined endocrine therapy and hopefully changed the natural history of especially early stage breast cancer, do the lobular patients particularly benefit from that? And so it's a question on everyone's mind. I think it's really hard to design studies around specifically lobular patients just for some practical reasons, but it doesn't mean that we shouldn't stop trying.
Part of the risk, right? And the size, you can't measure it for like, when you showed the tumor sizing, it's.
Right.
And another thing is in a lot of the screening studies, since it's not being picked up by the regular diagnostics, right? You're not seeing it in a lot of the studies, right? But yes, important in the blood test studies is the inclusion of lobular, which is something we specifically look at and recruit for the studies, because you need to have, in a blood test for screening, you need to be across the subtypes, and that will continue to expand as there are higher numbers. But also we're using, for example, sites that have MRI so that we can detect more of the tumors that are missed a lot by, for example, mammography.
Thanks, everyone.
Thank you.